Um, Welcome everyone. We're just so glad to have you with us today for another deep dive.
Absolutely. It's great to be here.
I want you to start by just picturing something in your mind for a second. Imagine a biological engine.
Okay.
It's perfectly constructed, right? Meticulously engineered over millions of years of evolution. And it has a completely clear path laid out right in front of it.
No roadblocks.
Exactly. No barricades, no structural impediments standing in its way at all. But when the precise developmental moment arrives, and it is time to go,
It just refuses to start.
it simply refuses.
Yeah.
You turn the key, try to jumpstart it, and absolutely nothing happens. The machinery is physically intact, yet the internal propulsion system is just fundamentally dead.
It's a great analogy for what we're looking at today.
Right, because today's mission is to explore exactly that scenario. But inside the human jaw, we are diving into one of the most fascinating and, quite frankly, frustrating mysteries in dental and osteological science.
Primary failure of eruption.
Yes, widely known in the field as PFE.
And it is a remarkable anomaly. To really grasp the mechanics of what is happening here, or I guess rather what isn't happening, we're going to be synthesizing a tremendous amount of clinical data today.
We've got quite the stack of sources on the table.
We really do. We're looking across contemporary orthodontic literature, the latest clinical handbooks, and some highly detailed postgraduate diagnostic notes to build a complete picture of this condition.
From the macroscopic to the microscopic.
Exactly. From cellular interactions in the periodontal ligament all the way up to the broad sweeping surgical interventions required when the body's natural eruptive forces completely abandon us.
So our mission today, really, is to extract the ultimate aha moments from all of this complex material. We're going to transform what might initially sound like this niche developmental glitch into a sweeping masterclass.
A masterclass on genetics, biomechanics, and the limits of intervention.
Right. The profound limits of human medical intervention. By the end of this deep dive, you are going to understand why sometimes, despite all of our technological advancements, the absolute smartest thing a clinician can do is step back and do nothing at all.
It's a hard lesson for a lot of practitioners.
It is. Okay, so let's
Okay.
unpack this. We need to establish a baseline first. Before we can understand how this biological engine breaks down, how is a tooth actually supposed to erupt into the mouth normally?
Well, the normal process of a tooth navigating its way through the human skull and emerging into the oral cavity it's nothing short of a physiological marvel.
It really is.
It's a highly coordinated, multi-step cellular ballet. For a permanent tooth to emerge, it typically has to deal with the primary tooth that's occupying the space right above it.
The baby tooth.
Right. And it achieves this by initiating a process of root resorption. The body essentially summons specialized cells to dissolve the root of the primary tooth so that the crown eventually loses its anchor and sheds.
Shedding that predecessor is really only a fraction of the battle, right?
A tiny fraction. Because once that overlying tooth is gone, the permanent tooth still has to travel through solid bone to reach the surface.
I was reading the data on this, and it indicates that a first permanent molar, for instance, has to traverse a total eruption path of about 2.5 centimeters.
Which is massive in this context.
Right. Like 2.5 centimeters might sound negligible if you're just measuring a piece of string on a desk.
But in the dense, highly constrained microenvironment of a growing pediatric jaw.
It's an incredibly long and arduous journey.
It is. And interestingly, nearly half of that specific distance is actually covered after the tooth has reached the occlusal level.
The active bite line.
Exactly. Because the tooth has to continually erupt to compensate for the ongoing vertical growth of the facial skeleton.
But to even make that initial vertical climb up to the bite line, the body has to carve out a tunnel first.
It does. It recruits and activates osteoclasts.
Those are the bone-dissolving cells.
Yes, the large, multinucleated cells responsible for bone resorption. They lead the charge, literally dissolving the overlying alveolar bone and clearing a distinct eruption pathway for the crown of the tooth to follow.
Okay, but creating a tunnel is not the same thing as moving through it.
Not at all. You can blast a tunnel through a mountain, but a train still needs a locomotive to push it forward. In the context of the jaw, there has to be a propulsive force.
And this is where the mystery usually deepens. What exactly is the motor pushing that tooth upward through the bone once the osteoclasts have cleared the way?
That is the million-dollar question in orthodontics right there.
We still don't fully know.
Well, despite decades of intense histological research, the precise mechanism generating that pre-emergent propulsive force remains a subject of debate. It's definitely multifactorial.
Okay, what are the leading theories?
Current evidence points toward a combination of things. Localized variations in vascular pressure beneath the tooth, pushing it upward. And it heavily involves the periodontal ligament, or the PDL.
The PDL, right.
Researchers believe it involves the contraction of fibroblasts.
And those are what exactly?
They're essentially the architectural builder cells of our connective tissues. The theory is they are pulling the tooth along the path. And furthermore, there are significant alterations in the ground substance of the PDL.
Okay, let's break down that term, ground substance, just to make sure we're all visualizing this correctly. We aren't talking about something rigid, are we?
No, not at all. The ground substance is the amorphous, gel-like matrix in which the cells and fibers of the connective tissue are embedded.
So it's squishy.
Yes, and it's highly active.
Yeah.
Changes in the hydration and biochemical makeup of this gel-like substance create localized swelling and pressures.
And that swelling pushes the tooth.
That's the idea. It likely contributes to pushing the tooth occlusally. So you have vascular pressure, fibroblast contraction, and ground substance dynamics all acting together as the engine.
Got it. So we have the osteoclasts acting as the bulldozers clearing the road, and this complex PDL matrix acting as the engine driving the car.
Perfect analogy.
Now let's look at what happens when there is a mechanical obstruction, because this provides a really crucial contrast to PFE.
Right.
Sometimes the engine is working perfectly, but the road is blocked. You might encounter an ankylosed primary tooth, where the baby tooth has pathologically fused directly to the jawbone and just acts as a concrete barricade.
Or perhaps there's a supernumerary tooth.
An extra tooth?
Yeah, an extra malformed tooth developing right in the eruption path. Or you might see it in syndromic conditions.
Like what?
Take cleidocranial dysplasia, for example.
Okay.
It's a skeletal condition that primarily affects the development of the collarbones and the skull. But in the mouth, it results in extremely dense, thickened, heavy, fibrous gingival tissue and multiple supernumerary teeth.
So the gums are just too thick for the tooth to break through.
The bone and the gums themselves act as an impenetrable physical barrier. But in all of these mechanical obstruction scenarios, the eruptive engine of the permanent tooth is firing on all cylinders.
The motor is running.
Yes. The vascular pressure is there, the fibroblasts are contracting, but the tooth is physically trapped.
Which brings to mind that fascinating animal model they always cite in the dental research, the Aya mice.
Ah, yes, the Aya mice. They are a perfect illustration of this mechanical failure. The Aya stands for incisors absent.
Poor little guys.
It's a specific mutant strain of mice where the fundamental bone resorption process, the bulldozer phase, fails completely. The osteoclasts are defective.
So they can't clear the tunnel.
Right. Because the bone directly above the developing incisors refuses to dissolve, the teeth are mechanically trapped within the jaw. They never emerge.
But the engine is fine.
Exactly. The internal propulsive engine of the tooth is fine. If a researcher or a surgeon goes in and physically removes that overlying bone,
Takes away the barricade.
yes, taking away that mechanical interference, the trapped tooth will suddenly spring into action and erupt normally.
Wow.
Or in a human patient, once the roadblock is surgically cleared, the tooth can easily be guided into its proper position using standard orthodontic hardware.
And that perfectly sets the stage for the true star of today's deep dive, primary failure of eruption. Because PFE just completely flips that script.
It does.
In a patient with PFE, there is absolutely zero mechanical interference.
None.
The osteoclasts have done their job beautifully. The highway is wide open. The sources mention that if an oral surgeon reflects the gums and looks down at the bone, there's a clear, patent eruption pathway.
They probe the tooth and find no ankylosis. The tooth is sitting freely in its follicle. It's not fused to the bone at all.
There are no extra teeth blocking it, no dense fibrous tissues. Everything looks perfect. But the permanent teeth simply sit there in the jaw, refusing to erupt.
And it is a profound clinical finding because it isolates the variable. PFE proves unequivocally that simply having a clear pre-emergent path is insufficient for tooth eruption.
The tunnel isn't enough.
Right. The fundamental defect in PFE lies within the propulsive mechanism itself. The complex biochemical signaling required to activate those fibroblasts, alter that ground substance, and generate that vascular pressure is just completely absent.
So, back to our analogy. You've cleared a massive traffic jam, opened up all 5 lanes of the highway, swept the asphalt clean, and the car still just sits there because the engine block is cracked.
Precisely.
And what makes this clinical presentation so bizarre is its localization. This engine failure doesn't happen everywhere in the mouth, does it?
No, the phenotypic presentation is strikingly specific. It almost exclusively targets the posterior dentition.
The back teeth.
Yes. The molars are universally affected, the premolars are frequently involved, but the anterior teeth, the incisors and the canines, almost always erupt perfectly normally.
So you have a patient who smiles, and from the front, everything looks entirely healthy and developmentally appropriate.
But if you look toward the back of their mouth, it's an absolute disaster zone of submerged teeth that have essentially abandoned their biological imperative.
For decades, this just baffled the profession, didn't it?
Utterly baffled them. Dentists would look at these submerged molars, assume they were just being a little stubborn, glue some brackets on them, apply traction, and then just watch their treatment plans completely fall apart.
Which begs the question, how did we finally figure out that the engine was dead? What actually cracked the code on PFE?
The paradigm shifted completely in 2009.
Okay, what happened in 2009?
That was the year researchers finally isolated the genetic blueprint of the condition. They transitioned PFE from a mysterious clinical frustration into a definable, genetically linked disease.
They found the broken code.
They discovered that a specific genetic mutation leads directly to this failure of the eruptive engine. This meant clinicians could finally move away from trial and error biomechanics and start utilizing targeted molecular diagnostics.
Let's talk about what they found hiding in the DNA, because it is incredibly specific.
It is. The culprit is a mutation in the parathyroid hormone receptor 1 gene.
Universally abbreviated as PTH1R, right?
Yeah, correct. PTH1R. Specifically, researchers identified it as a loss-of-function mutation. And to really understand the gravity of this, we have to look at what this receptor normally does in a healthy human.
Right, because the gene makes a receptor.
Exactly. The PTH1R gene provides instructions for making a receptor protein that sits on the cell membrane. This receptor's job is to bind to parathyroid hormone and a related peptide.
And parathyroid hormone is a major systemic player, right? It isn't just hanging out in the gums.
Far from it. Parathyroid hormone is a master regulator of calcium homeostasis and bone metabolism throughout the entire body.
So it's systemic.
Yes. But in the specific microenvironment of a developing tooth, this hormone and its receptor are absolutely vital for mediating normal cellular functions during eruption. The osteoblasts and the cells within the dental follicle rely on this signaling pathway to coordinate the entire eruptive cascade.
So when you have loss-of-function mutation in PTH1R,
The receptor is essentially deaf. The hormone is circulating in the blood, it's trying to deliver the signal to activate the eruptive engine, but the receptor cannot hear it. The biochemical cascade just fails to trigger.
the engine wiring is fundamentally faulty right from the factory line.
Exactly.
Now, the way this mutation passes through families is where the clinical reality gets incredibly complicated. The data shows that PFE follows an autosomal dominant inheritance pattern,
Right.
meaning you only need to inherit one copy of the mutated gene from one parent to manifest the condition. But it is not a simple one-to-one translation, is it? We are dealing with something geneticists call variable expressivity.
Variable expressivity is one of the most challenging aspects of genetic counseling and treatment planning. It means that even when a parent and a child possess the exact same genetic mutation,
The exact same spelling error in the DNA.
yes, the exact same spelling error in their PTH1R gene, the physical manifestation of that mutation, the phenotype, can look wildly different between them.
Can you walk us through a hypothetical scenario of what that variable expressivity actually looks like in a family?
Certainly. Imagine a mother who possesses the PTH1R mutation. In her case, the expressivity is very mild.
Okay.
Perhaps she only had a single second molar that was slightly delayed in its eruption, or it sits just a fraction of a millimeter below the bite line. It barely affected her ability to chew, and her dentist might not have even flagged it as a major anomaly.
Just a slightly stubborn tooth.
Right. Now, she passes that exact same autosomal dominant gene to her daughter. But in the daughter, the expressivity is severe.
Oh, wow.
Every single molar and premolar in all 4 quadrants of her mouth fails to erupt. They remain entirely buried deep within the jawbone, resulting in a catastrophic inability to chew and requiring massive, life-altering craniofacial surgeries.
From the exact same gene.
The underlying code is identical, but the way the body reads and executes that code is vastly different. You absolutely cannot predict the clinical severity in the child based on the clinical presentation of the parent.
That has to be an incredibly difficult conversation for a clinician to have with a family.
It is heartbreaking sometimes.
But wait, if we know the exact gene, and we know it's autosomal dominant, why not just run a DNA swab on every pediatric patient with a delayed molar and get a definitive yes or no? Is the genetic testing a silver bullet?
Unfortunately, no. While a positive genetic test for the PTH1R mutation is a definitive confirmation of PFE, a negative test does not rule it out.
Why not?
There is a significant false negative rate, and this comes down to the immense complexity of human genetics. The 2009 breakthrough identified mutations within the specific coding region, the exons of the PTH1R gene.
The main instruction manual.
Right. However, genetic regulation involves much more than just the primary coding sequence.
So we are talking about mutations hiding in the non-coding regions.
Exactly. You could have a patient with a perfectly normal coding sequence for the receptor, but they might possess a mutation in a distant enhancer region, an intron, or a promoter region.
And those regions act like volume knobs, right?
Yes, they dictate how much of the receptor is produced or where it is expressed. Furthermore, while PTH1R is the primary locus we've identified, tooth eruption is a polygenic trait.
Meaning multiple genes are involved.
Right. There are likely other, currently unidentified genes that interact within this biochemical pathway. If a mutation occurs in one of those secondary genes, the engine still fails, but the PTH1R test will come back completely normal.
It highlights how much of the map is still blank. But speaking of the map, there is a systemic connection here in the sources that completely blew my mind.
The osteoarthritis link.
Yes, we are talking about a localized failure of posterior teeth to erupt. But because this involves a fundamental receptor for bone metabolism, the collateral damage isn't just confined to the jaw.
No, it's not.
The research suggests that these same autosomal dominant mutations in the PTH1R gene might also be associated with early onset osteoarthritis.
It is a profound systemic link. Osteoarthritis is characterized by the degenerative breakdown of joint cartilage and the underlying subchondral bone.
Like in your knees or hands.
Right. And when you step back and look at the whole organism, it makes perfect biological sense. You have a systemic mutation affecting a fundamental receptor that dictates how cells build and maintain bone and cartilage matrices.
The blueprint is flawed everywhere.
Exactly. The effects of that faulty signaling aren't going to politely restrict themselves to the periodontal ligament. Finding this genetic bridge between a rare dental eruption failure and a widespread, debilitating joint condition underscores a critical reality in medicine.
Which is?
There is no such thing as an isolated system. The biochemical pathways orchestrating the eruption of a molar are intrinsically tied to the pathways maintaining the cartilage in your knees and hands.
Incredible.
Okay.
So we have established that the engine is biochemically dead, the genetic blueprint is compromised, and the effects can be systemic. But let's bring this back down to the dental chair.
Okay.
What does this anomaly actually look like when a patient opens their mouth?
Yeah.
How does a clinician spot the clinical fingerprint of PFE?
Let's start with the epidemiological data to frame who we are actually looking at. PFE is a rare condition. The incidence is estimated at approximately 0.6% of the general population.
That's less than 1 in 100.
Very rare. And as we discussed with the genetics, there is a strong familial predilection observed in roughly 10 to 40% of diagnosed cases.
So it runs in families quite often.
It does. Demographically, it presents with a higher frequency in females than in males, and from an orthodontic standpoint, it is highly correlated with Class 3 malocclusions.
Let me clarify for everyone listening. A Class 3 malocclusion is the skeletal pattern typically associated with a pronounced underbite, right? Where the mandible, the lower jaw grows further forward than the maxilla.
Yes, the classic underbite.
Why would PFE be linked to that specific skeletal growth pattern?
It's an excellent question, and it likely relates back to the underlying genetic pathways again. The genes influencing the downward and forward growth vector of the mandible may have overlapping regulatory mechanisms with the pathways governing posterior tooth eruption.
So they share a genetic neighborhood.
Yes. While the exact causal link is still being unraveled by geneticists, the correlation is a massive red flag for clinicians. If you see a developing Class 3 skeletal pattern accompanied by delayed posterior eruption, PFE should immediately move to the top of your differential diagnosis.
But the absolute defining clinical feature, the hallmark that sets off alarm bells, is the presence of a severe posterior open bite.
Yes. The teeth are what the literature calls infraoccluded.
Meaning they are physically stuck at a vertical level below the active bite line.
Right. If you ask a severe PFE patient to bite down, their front incisors will meet perfectly. But as you look toward the back of the mouth, there is a massive, visible gap of empty space between the upper and lower molars.
They literally can't close the gap.
They cannot physically chew anything in the posterior segments because the opposing teeth never make contact.
Now, to help clinicians categorize this severity and plan accordingly, the field utilizes something called the Fraser-Bowers 2007 classification system.
Yes, Sylvia Fraser-Bowers' work on this was groundbreaking.
This framework divides PFE into two distinct types based on their clinical and developmental presentation. Walk us through Type 1.
Type 1 is defined by a progressive anterior to posterior lateral open bite. In a Type 1 presentation, absolutely none of the involved teeth possess any eruptive potential. They are completely paralyzed.
And interestingly, this type seems to be tied to the patient's chronological age rather than the developmental stage of the tooth itself.
That's right. At a certain chronological point, the eruptive mechanism simply shuts down simultaneously across all affected teeth.
Like a master switch gets flipped.
Exactly, regardless of how far along their roots are in forming.
And how does Type 2 differ from that?
Type 2 presents differently. In Type 2 PFE, the teeth distal to the primary affected tooth, meaning the teeth located further back in the dental arch, exhibit a smaller lateral open bite, but they still show clearly inadequate eruption.
So it's not a total shutdown.
Unlike Type 1, the failure in Type 2 seems to correlate much more strongly with the specific developmental stage of the root of the individual tooth. It's less of a sudden synchronized shutdown and more of a progressive failure as the roots attempt to mature.
This brings us to a diagnostic principle that is simultaneously incredibly reliable and clinically devastating.
The distal cascade rule.
Yes, the distal cascade rule. It sounds like a bad sci-fi movie, but it's very real.
It's the unforgiving mathematical law of PFE. It dictates that if a specific tooth is definitively affected by primary failure of eruption, every single tooth located distal to it, meaning every tooth behind it in that specific quadrant of the jaw, will also be affected and will fail to erupt normally.
So if a clinician determines that a patient's first premolar has PFE,
the prognosis for the rest of that quadrant is already written.
the second premolar, the first molar, the second molar, the wisdom teeth.
They are all doomed. The cascade effectively wipes out the entire functional posterior segment of that arch.
But it gets even stranger. The presentation doesn't have to be symmetrical, does it?
Not at all. The asymmetry can be staggering. You can review clinical cases where the left side of a patient's mandible presents as a severe Type 1 PFE, with the premolars and all molars deeply submerged in a massive posterior open bite.
And on the other side.
On the exact same patient's right side, there might only be a single mildly affected second molar. Or perhaps the entire right side has erupted flawlessly.
That's wild.
The cellular execution of the genetic code can vary wildly from 1 millimeter of jawbone to the next.
That level of unpredictability must make treatment planning an absolute nightmare. But let's get into the mechanics of why standard treatment fails so spectacularly. Let's talk about the orthodontic trap.
This is where things get really critical.
Because for a parent sitting in the consult room, the solution seems incredibly obvious. You have a tooth that is stuck in the bone. There is no physical barricade blocking it. Orthodontists specialize in moving teeth.
Right.
Why not just bond a titanium bracket to the submerged tooth, attach a wire, and physically pull it up into the mouth?
It is the most intuitive, logical conclusion a person could draw. And historically, before the pathology of PFE was fully understood, it is exactly what the orthodontic profession attempted to do.
Did you put braces on it?
Clinicians would apply traction, fully expecting the tooth to yield to the mechanical force. But this is where the biological trap snaps shut. PFE teeth absolutely do not respond to continuous orthodontic force.
They don't budge.
Not only do they not budge, if you attempt to extrude a PFE tooth using standard biomechanics, it will not move upward into the arch. Instead, after a very brief period of initial microscopic movement, the tooth will rapidly and permanently ankylose.
It fuses to the bone.
It will fuse directly and inextricably to the surrounding alveolar bone.
Let's unpack the biomechanics of why it happens. Because a normal tooth doesn't just fuse to the bone when you pull on it.
No, in a healthy tooth, the root is not directly connected to the jawbone. It is suspended in a hammock of connective tissue called the periodontal ligament.
The PDL again.
Right. This PDL acts as a shock absorber and a highly vascularized remodeling zone. When an orthodontist applies continuous force to a healthy tooth, the PDL responds.
How so?
On the side where the tooth is being pushed, osteoclasts resorb the bone to make room. On the side where the tooth is being pulled away, osteoblasts build new bone to fill the gap.
So it remodels the bone around it.
Exactly. The tooth moves smoothly through the bone, guided by the PDL, but in a PFE tooth, that system is fundamentally broken.
Because the receptors are deaf.
Yes. When continuous extrusive force is applied, the compromised PDL space is rapidly obliterated. The root surface comes into direct physical contact with the alveolar bone, and the body reacts by calcifying that junction.
It turns into concrete.
The tooth and the bone become one solid, continuous block of calcium.
The tooth ceases to be an independent organ and becomes a structural pillar of the jaw itself. And this is where we have to talk about Newton's third law in the context of the human mouth.
For every action, there is an equal and opposite reaction.
Right. When an orthodontist activates a wire to pull a stuck tooth upward, that wire isn't just floating in space. It has to anchor itself to something else to generate that pulling force.
Precisely. Orthodontic mechanics rely on anchorage. To pull a submerged molar up, the clinician must anchor the wire to the healthy erupted teeth adjacent to it, typically the premolars and anterior teeth.
The anchor teeth.
Right. In a normal scenario, the resistance of the erupting tooth is low enough that it moves upward, while the heavy, multi-rooted anchor teeth remain relatively stable. But a PFE tooth that has ankylosed presents near infinite resistance.
It is an immovable object.
It really is.
So the wire is applying a massive upward force on a tooth that is literally fused to the skull, that's simultaneously applying an equal and opposite downward force on the perfectly healthy anchor teeth.
And because the PFE tooth cannot and will not yield, all of that kinetic energy is transferred directly into the healthy anchor teeth.
Oh, no.
The healthy teeth are rapidly intruded, meaning they are driven downward deep into the alveolar bone.
So the doctor, attempting to fix a single localized problem, inadvertently causes catastrophic iatrogenic harm.
Yes. They destroy the healthy segments of the patient's bite, creating a massive iatrogenic open bite that is incredibly difficult to correct later.
It is a biomechanical disaster. You try to pull the drowning tooth out of the water, and instead it drags the entire rescue boat down to the bottom of the ocean.
It's a perfect way to visualize it.
This highlights the absolute, non-negotiable importance of achieving a correct diagnosis before any brackets are glued on. But the problem is, diagnosing ankylosis before you apply force is incredibly difficult, isn't it?
Extremely difficult.
Why can't we just look at an X-ray and see that the tooth is fused to the bone?
That is the cruel irony of the diagnostic process. Our standard imaging modalities simply lack the necessary resolution to definitively prove ankylosis in these early stages.
But what about the standard panoramic X-ray, the OPG everyone gets?
The OPG that every patient gets during a consult is notoriously unreliable for this specific task. The literature demonstrates that OPGs have a staggering 30 to 50% false positive rate when attempting to detect ankylosis.
So it's essentially a coin toss. The X-ray might show what looks like a fusion point, but it's just a shadow or an artifact of the 2D projection.
Exactly.
But what about 3D imaging? Almost every modern orthodontic office has a CBCT scanner now. Surely a 3D scan can see the fusion.
Cone beam computed tomography is a massive leap forward, absolutely. But even CBCT is fallible when dealing with structures this microscopic.
All right.
The sources indicate that CBCT scans only yield about a 60 to 70% sensitivity for detecting ankylosis. You have to consider the physical dimensions we are analyzing here. The periodontal ligament space in a healthy tooth is roughly 0.2 millimeters wide.
That is incredibly thin.
Very thin. CBCT images are composed of tiny 3D pixels called voxels. If the voxel size isn't small enough, or if there is slight patient movement, or if there is beam hardening artifact from the dense enamel of the crown,
The space just blurs out.
that 0.2 millimeter space visually disappears on the scan entirely. It will look like the root is fused to the bone even when it isn't. Conversely, tiny pinpoint areas of true ankylosis might be entirely missed by the scan.
So the advanced imaging gives us hints, but no real certainty, which leads to a terrifying conclusion found in the clinical literature. The only definitive, incontrovertible proof that a tooth is ankylosed is its complete lack of clinical response to applied mechanical traction.
Exactly. The ultimate diagnostic test is therapeutic failure.
That's awful.
You only know for absolute certain that you are dealing with PFE and ankylosis when you apply force. The target tooth remains entirely static and your anchor teeth begin to intrude.
But by the time you observe that occurring,
You have already initiated the exact iatrogenic damage you are desperately trying to avoid.
it's the ultimate catch-22 in orthodontics. You have to spring the trap to know the trap is actually there, which perfectly sets up the ultimate diagnostic dilemma that clinicians face every day in practice, the first molar conundrum.
This is where clinical judgment really gets tested.
I want you to step into the shoes of a pediatric dentist or an orthodontist for a moment. Imagine a patient, let's say an 8-year-old girl, sitting in your chair. You look at her panoramic x-ray. Everything looks developmentally appropriate for her age, except for one glaring anomaly.
A single mandibular first molar is deeply unerupted.
Yes, it is sitting low in the bone while all the other first molars have come in perfectly. You are staring at this single stuck tooth, and you have to make a choice. Is this an isolated case of mechanical ankylosis? Perhaps she bumped her jaw years ago and damaged the PDL? Or are you looking at the first warning sign of primary failure of eruption?
This specific scenario is the crucible of clinical judgment. How a clinician responds to that single unerupted first molar dictates the entire future of that child's jaw development.
Because the management pathways for those two distinct diagnoses are radically fundamentally opposed.
Right. To navigate this, we have to rely on a strict logical framework and look at the developmental sequence occurring behind that stuck tooth.
Okay, let's map out that logic tree. Let's explore path number 1. What if that single unerupted molar is indeed the first symptom of PFE?
If it is PFE, we must immediately apply the distal cascade rule we discussed earlier.
The mathematical law.
Yes. If the first molar is genetically compromised by PFE, it guarantees that the second molar, which is currently just a germ developing in the bone behind and below it, is also compromised. The entire distal segment is destined to fail. That second molar will never erupt normally.
Okay, now let's explore path number 2. What if it is not genetic? What if it is just a case of isolated mechanical ankylosis of that single first molar?
If it is isolated ankylosis, the fundamental propulsive engine of the surrounding teeth is perfectly intact. Therefore, the second molar developing behind it is completely healthy. It possesses full eruptive potential.
So it's trying to push up.
In fact, because the ankylosed first molar is stuck below the occlusal plane, it leaves a spatial void in the arch. The healthy second molar will likely attempt to erupt and then forcefully drift mesally.
Meaning it will tilt and drift forward toward the front of the mouth.
Yes, in a biological attempt to close that empty space.
So as the clinician staring at the x-ray, you don't know which future is waiting to unfold. Do you just observe? Do you tell the parents, hey, let's bring her back in 6 months and see what happens?
Wait and see is often the most dangerous course of action in this specific scenario. The literature strongly cautions against passive observation.
Why?
Because as the 8-year-old child continues to grow, her mandible will grow significantly in a vertical dimension. The healthy teeth will continue to erupt, carrying the alveolar bone up with them.
Oh, but the stuck tooth.
The ankylosed tooth will remain statically locked in its current spatial coordinates. Over several years, this creates a massive, localized vertical bone defect. The bone around the stuck tooth will be vastly lower than the bone in the rest of the jaw, creating a horrific anatomical defect that is nearly impossible to repair later in life.
So observation is out. Applying braces is out because it might be PFE and you'll destroy the anchor teeth.
Yeah.
What is the clinician left with? This brings us to a strategy I find absolutely fascinating. The extraction gambit. What is the recommended protocol here?
The recommended clinical pathway, born out of necessity and evidence-based pragmatism, is aggressive but brilliant. The protocol dictates that the clinician should proactively extract that unerupted first molar as early as possible.
You simply remove the tooth from the board.
Yes.
Let me play devil's advocate here, because if I am a parent, that sounds absolutely terrifying. You are telling me that my daughter has a tooth stuck in her jaw, you don't know for sure what is causing it, and your solution is to surgically rip it out. Isn't that a massive violation of the first do no harm principle?
It definitely sounds aggressive.
Why amputate a potentially healthy, albeit stuck, body part based on a guess?
You have to evaluate the biomechanical consequences of the two possible futures. The extraction gambit is essentially a hedge against pathology. Let's walk through the logic.
Okay, lay it out.
Assume for a moment the optimistic scenario. The first molar was suffering from isolated ankylosis, and the second molar behind it is perfectly healthy. By surgically extracting the stink first molar, you completely remove the physical roadblock.
And what happens next?
What happens next is a biological rescue mission. The healthy second molar, driven by its intact propulsive engine, will erupt and naturally drift mesally into the space you just vacated.
But wait, earlier you said the big danger was losing vertical bone height. If we extract the first molar, won't we lose all the bone in that area anyway?
This is where the magic of the periodontal ligament comes into play again. The alveolar bone, the specific highly porous bone that houses the roots of the teeth, is entirely dependent on the presence and movement of teeth to maintain its volume.
Use it or lose it.
Exactly. When a healthy tooth erupts and drifts through the jaw, it doesn't just move through the bone, it brings the bone with it. The PDL coordinates a continuous cycle of bone apposition.
So it builds bone as it moves.
Yes. So as the healthy second molar drifts forward into the extraction site, it naturally generates and drags a massive volume of healthy vertical alveolar bone along with it. The body essentially heals its own defect, providing excellent bone volume for a functional bite or, if needed, a future implant.
Okay, that covers the optimistic scenario. You sacrifice one tooth to allow the second tooth to rescue the jawbone. But what about the pessimistic scenario? What if the clinician pulls the first molar and it turns out the child actually has severe PFE?
If the underlying diagnosis was PFE, the extraction gambit is still the correct mathematical play. Remember the distal cascade rule.
Right, the doom cascade.
If the first molar had PFE, that second molar was genetically doomed from the start. It was never going to erupt. The entire posterior quadrant is compromised. Therefore, by extracting the first molar early, you haven't actually lost a functional tooth, because that tooth and everything behind it was destined for surgical removal or profound dysfunction anyway.
It is an incredible display of clinical chess. You are thinking 3 biological moves ahead of the pathology. If it's isolated ankylosis, you facilitate a natural, healthy, self-correcting drift that builds bone.
And if it's PFE, you are simply taking the first necessary step in managing a genetically ruined quadrant.
You have nothing to lose with early extraction in this specific diagnostic dilemma, and absolutely everything to gain in terms of long-term bone preservation.
Exactly. It relies heavily on an understanding of alveolar bone dynamics. You're trading a static ankylosed piece of anatomy that guarantees future bone defects for the dynamic bone-building potential of an erupting tooth.
Which brings us to the final and perhaps most sobering segment of our deep dive, navigating the aftermath. Because once you execute that gambit, or once you definitively diagnose a severe case of PFE, the reality of treatment planning shifts dramatically. It requires an enormous amount of humility from the medical team.
Humility is truly the operative word. We operate in a modern medical culture that heavily prioritizes aggressive intervention. We want to fix, move, cut, and correct every anomaly we see.
We're fixers.
PFE forces the clinician to confront their absolute limitations. It demands that we recognize that sometimes the most potent and effective tool a highly trained specialist possesses is knowing exactly when not to use their tools.
Knowing to withhold orthodontic brackets saves the patient from an immense, irreversible iatrogenic destruction.
Precisely.
So if the brackets are off the table, what are the actual therapeutic options for a patient living with PFE? How do you manage a bite that doesn't meet? Let's start with the mild cases.
The treatment algorithm is highly dependent on severity. For mild presentations, perhaps the type 2 where only the second molars are slightly infraoccluded and the patient has a perfectly functional, stable bite in the anterior and premolar regions, the gold standard of care is often observation and acceptance. The clinician does absolutely nothing.
You just leave them buried.
Yes. The patient accepts what is known clinically as a shortened dental arch or a premolar occlusion. They simply chew their food using their front teeth and premolars.
That sounds limiting, but I guess it works.
The buried molars are monitored radiographically for pathology like cyst formation, but otherwise they are left strictly alone. It is not the anatomical ideal we strive for in a textbook, but it is highly functional, and it spares the patient from a lifetime of invasive, painful, and costly surgical procedures.
But what if the tooth has managed to erupt partially? It broke through the gums, but the engine died halfway up, and now it sits a few millimeters shy of the opposing tooth. Can we help that patient without surgery?
In those moderate scenarios, we pivot from orthodontics to prosthodontics. We cannot move the root of the tooth upward through the bone, but we can alter the anatomical crown of the tooth.
How does that work?
Dentists can utilize adhesive dentistry to place composite resin buildups, literally bonding layers of tooth-colored material to the occlusal surface of the stuck tooth to artificially raise its height.
Adding height to the top.
Or, alternatively, they can prick the tooth and place a full-coverage prosthetic crown made of porcelain or metal that is intentionally designed to be extra tall.
You are essentially building a skyscraper on top of a very short sunken foundation so that it finally reaches the height of the surrounding buildings.
Precisely. You establish functional occlusal contact artificially. However, the biomechanical limitations of this are obvious. You cannot build a crown that is a centimeter tall.
Right. The physics wouldn't work.
The sheer leverage forces exerted during chewing would fracture the porcelain, snap the composite, or physically snap the root of the underlying tooth.
Which brings us to the severe, devastating cases, the type 1 presentations, where multiple premolars and molars are deeply buried in the basal bone of the jaw. You can't observe them because the patient has no posterior bite. You can't build giant crowns. So what is the surgical endgame?
For severe PFE, the interventions become intensely aggressive feats of surgical engineering. Because the biological reality is that you cannot move the teeth through the bone, the only remaining option is to surgically detach and move the bone itself.
Moving the bone.
Oral and maxillofacial surgeons employ major orthodontic procedures, primarily segmental osteotomies and distraction osteogenesis.
Okay, let's break those down. What exactly is a segmental osteotomy in this context?
In a mandibular posterior segmental osteotomy, the surgeon makes highly precise osteotomies through the jawbone. They literally saw out a rectangular block of the alveolar bone that completely encases the buried PFE teeth, severing it from the basal bone beneath it while carefully preserving the blood supply.
And then what?
They then physically lift that entire block of bone, teeth, and all upward into the correct occlusal plane and rigidly fixate it into its new position using titanium plates and screws.
Wow.
The body eventually heals the bony gaps, and the teeth are now at the proper height because the ground beneath them was elevated.
That is incredible. They just cut the entire neighborhood out of the earth and elevate it. And what about distraction osteogenesis? How does that differ?
Distraction osteogenesis is a technique originally developed by a Russian orthopedic surgeon named Gavril Ilizarov for lengthening limb bones, which has been brilliantly adapted for the craniofacial skeleton.
How does it work on a jaw?
Instead of moving the bone block all at once and plating it, the surgeon makes the cuts to free the bone block containing the teeth and then attaches a specialized mechanical distraction device. Part of the device is anchored to the stable basal jawbone, and part is anchored to the freed segment.
And then they just slowly crank it open.
Exactly. Over a period of weeks or months, the patient or clinician turns a tiny screw on the device a fraction of a millimeter every day. This incredibly slow, steady tension pulls the block of bone upward.
And the body just fills in the gap.
Yes, as the gap between the cut bones slowly widens, the body's natural healing response continually fills that void with new, healthy bone matrix. You are exploiting the body's fracture healing mechanism to organically grow new jawbone vertically. You aren't erupting the teeth, you are elevating the entire section of the jaw they live in.
It is absolute science fiction occurring in the dental chair. But as with everything regarding PFE, there is a massive catch. The literature dictates a very strict, non-negotiable timing constraint for these major surgical procedures, or even if a patient opts to just extract all the buried teeth and place titanium dental implants. When can these procedures actually be done?
The clinician must wait. They must defer all major definitive restorative or orthodontic surgical intervention until the patient has achieved complete 100% cessation of craniofacial growth.
Meaning they have to be done growing entirely.
Yes. For females, this might be around age 17 or 18. For males who continue to exhibit late mandibular growth, it might be well into their early 20s.
And what is the physiological reason behind that strict waiting period? Why can't you just place a dental implant in a 13-year-old who is missing their molars due to PFE?
Because of the foundational principles of craniofacial growth. As a teenager grows, their maxilla and mandible are actively growing downward and forward in space. Healthy teeth, suspended in their PDL, continually erupt and drift to keep up with this moving canvas.
But the hardware won't do that.
Right. Titanium dental implants, just like ankylosed PFE teeth, possess no PDL. They are osseointegrated directly into the bone. They're perfectly static. If you place a dental implant, or if you perform a segmental osteotomy and plate a block of bone into position on a 13-year-old, That specific hardware will not move or grow a single millimeter for the rest of their life.
But the rest of the face continues to grow around it.
Precisely. The surrounding healthy jawbone will continue its downward and forward trajectory for the next 8 years. The implant, which looked perfectly level at age 13, will be progressively left behind by the growing face.
Leaving a huge gap.
By the time that patient is 21, the implant will appear deeply submerged in the tissue, entirely out of occlusion, creating a massive aesthetic, structural, and functional defect that is incredibly difficult to revise. You simply cannot paint the final picture until the biological canvas has completely stopped shifting.
So these patients are subjected to a profound waiting game. A long, often frustrating adolescence spent navigating a compromised bite, requiring immense psychological resilience and a deep, patient understanding of their own biological limitations.
It is an arduous journey, and as we synthesize all the material we've covered today, PFE serves as the ultimate case study for a profound paradigm shift in dentistry, and indeed in medicine as a whole.
Moving away from the mechanical.
Right, for centuries, the medical mindset was heavily tilted toward mechanical dominance. The idea that if a physiological process is stalled, you simply apply external force to override it. If a tooth is stuck, pull harder.
Brute force biomechanics.
But our expanding understanding of genetics and cellular biology forces us to abandon that hubris. We now realize that sometimes the engine itself is fundamentally broken at a microscopic molecular level. The parathyroid hormone receptors are deaf, the biochemical signaling is absent, and the cellular machinery simply refuses to engage.
And it reminds us so vividly and violently how absolutely crucial accurate diagnosis is. Misdiagnosing a genetic failure like PFE as a simple mechanical hurdle, and then applying brute mechanical force in the form of braces, doesn't just fail to solve the problem.
It actively, aggressively destroys the remaining healthy architecture of the mouth.
It is the purest, most terrifying illustration of iatrogenic harm and the ultimate reinforcement of the clinician's oath. First, do no harm.
Absolutely. The progression of care for PFE, from blind mechanical pulling to targeted genetic testing to biological acceptance and strategic surgical delay, maps the maturity of the medical profession itself.
It's a humbling evolution.
And if we connect this highly specific dental anomaly back to the broader human experience, there is a profound philosophical takeaway. It is a lesson in respecting natural biological boundaries. We exist in a technological era that constantly promises us that with enough engineering, enough applied force, or enough willpower, we can conquer any physiological limitation.
But our biology has hard limits.
Immutable limits written directly into our DNA. Recognizing the true genetic root cause of a limitation saves an enormous amount of wasted clinical effort, financial resources, and irreversible physical damage. True advanced medicine isn't about fighting blindly against our biology. It is about deeply understanding it, respecting its parameters, and working intelligently within the boundaries it sets.
Respect the engine, especially when you know it's never going to start. Which leaves us with a final, lingering thought for you to mull over long after this deep dive ends. We've spent this time exploring how a simple DNA swab can now tell a surgeon definitively and unequivocally that a specific anatomical structure will permanently reject any mechanical force applied to it.
The resistance is hardwired into the genetic code.
So if we can map that biological refusal for a single tooth today, how far are we from a future where a quick genetic screen at birth maps out exactly which orthopedic therapies, which specific surgical interventions, or even which physical athletic training regimens our bodies will readily embrace, and which ones our cellular biology will stubbornly, permanently reject? If our DNA already holds the complete blueprint for our mechanical resistance, how much of our physical potential and our most frustrating physical limitations is already irrevocably written before we even take our first step? Thank you for taking this deep dive with us. We will see you next time.